Uh, okay, wait. 1 month old. One month after an uncomplicated vaginal delivery of 3,400 gram in newborn, 32-year-old woman gravida to para 2 comes to the physician because of 7-day history of tender mass in the left breast. Her pregnancy has been complicated by abdominal trauma sustained in motor vehicle collision, a second degree labor, a second degree mild vaginal laceration was repaired without difficulty after delivery. She is breastfeeding, temperature normal. Examination shows 3 into 3 centimeter fluctuant mass in the lateral aspect of the left breast, and the mass is mildly tender to palpation. The breast is not warm or erythematous. The breasts are symmetric. Which of the following is the most likely diagnosis? Okay, can I call you 1 minute later? I have an
Mhm.
important call. Okay, I'm okay.
Galactosile. Galactosile is a benign cyst of the mammary glands caused by obstruction to lactiferous duct outflow. Given its location, it's filled with milk rather than clear fluid. They occur in lactating women or women who just recently stopped lactating, and presents with a firm fluctuant mass that is painless or mildly tender and most commonly present in the subareolar area. Vital signs will be within normal limits. Diagnosis is typically clinical, but ultrasound can be completed, which will show a cystic mass. Galactocysts generally resolve on their own, but they can be aspirated or excised if they persist and are symptomatic. Complications are uncommon, but include superimposed infection and abscess formation, as well as rupture and subsequent inflammation.
Okay.
Okay, next.
20-year-old woman, gravida 2, para 1, 42 weeks of gestation, is admitted to the hospital in labor. She reports she reports severe abdominal pain. She reports severe abdominal pain, but she has received no prenatal care. She has no history of serious illness, takes no medication. Leopold maneuver indicates a fetus at term. The cervix is 10 centimeter dilated, 100% effaced. Surface is 10 centimeter dilated, 100% effaced. Vertex is at 2 plus station. After pushing for 3 hours with low force assisted delivery because is performed because of non-reassuring fetal heart tone and severe variable deceleration and maternal exhaustion. The operative vaginal delivery is 4200 4.2 kg, and newborn is complicated with shoulder dystocia and requires 8 minutes to reduce. On examination, the with newborn does not move the right arm. The forearm is pronated. Arm is adducted and internally rotated the shoulder. Okay, which of the following is the most likely cause? Is it Erb's palsy?
Probably. mm, mm, Forgot what route is that. Okay, ready?
Yes.
Okay. Cerebral palsy is characterized by adducted, adducted internally rotated arm secondary to injury of the upper brachial plexus, fifth and sixth cervical roots, C5, C6. This can occur during delivery as lateral traction is placed on the neck during a complicated birth, as in cases of shoulder dystocia or forceps assisted delivery. C5, C6 root control the deltoid, supraspinatus, and infraspinatus, and biceps brachii. Loss of the function of these muscles leads to adduction, okay, of the arm caused by failure of the deltoid and supraspinatus to abduct the arm, medial rotation of the arm because of failure of the infraspinatus to externally rotate the arm, okay, and extension pronation of the arm caused by failure of the biceps um, to flex and supinate the arm. Okay. Is not, which one was that? A. Fracture of the clavicle can be a complication of the dystocia or in extreme cases, it may be an intentional maneuver to help deliver a baby. Clavicle fractures can cause pain and decrease movement of the affected extremity, but they typically heal in 1 to 2 weeks. Okay. And then it's not C because injury to the eighth cervical root and first thoracic root. So C81 is often referred to as com, Comke palsy and can occur during a delivery requiring an upward force on the newborn arm. This injury leads to a dysfunction of the intrinsic hand muscles, including the lumbricals, interossei, and hypotenuse muscle. Comke. Okay.
Okay. A 32-year-old woman with type 1 diabetes mellitus has had increasingly severe perineal pain over the past 3 days. Her temperature is 39 degrees Celsius. 39 degrees Celsius. Pelvic examination shows a 5 into 5 centimeter dense cystic mass in the posterior labia majors with cellulitis extending past the right pubic hairline. Which of the following is the most serious complication of this uh, condition? Mm, Look at the area, posterior labius majors. Okay, with
Mm,
cellulitis. Extending to the okay. Okay. So
okay, so it's necrotizing fasciitis. A perineal abscess presenting as red edematous tender cystic mass of the perineum can be complicated by necrotizing fasciitis if left untreated. Necrotizing fasciitis is a severe bacterial infection involving the facial plane between the skin and muscle. Most commonly caused by mixed anaerobic and aerobic bacteria. It classically presents with red or purple discoloration over the skin, bulla, and crepitus, and exquisite tenderness on palpation. It spreads along the deep fascial plane, causing rapid extension of the infection, which is often difficult to appreciate visually. Vital signs may disclose fever, tachycardia, and hypotension. Risk factors include previous trauma to the infected site and systemic disease such as diabetes, renal failure, and liver failure. Um, Necrotizing fasciitis is a surgical emergency and requires immediate surgical debridement, broad spectrum antibiotic and fluid resuscitation. When occurring in the perineum, it's known as Fournier's gangrene. It's not Bartholin gland abscess. It's typically preceded by Bartholin gland cyst, which appears as a swollen mass in the introitus. If left untreated, the cyst can progress to an abscess with the development of redness and tenderness to palpation. Formation of another abscess will not be will not be as serious as the development of necrotizing infection. It's not gram-positive sepsis. Um, is most gram-positive sepsis is most commonly caused by introduction of skin or GI flora into the bloodstream. It can be caused by skin infections, indwelling catheters, both urinary and central catheters, and UTIs. While it will be possible for the patient to develop sepsis, a more pressing complication will be the development of fasciitis, which will require emergent surgical debridement. It is not perirectal abscess, refers to an abscess formation around the rectum, which presents with redness, fluctuant and tender mass. The patient infection could spread to the perirectal area, but this will be less worrisome complication than necrotizing fasciitis because it could be treated with non-emergent incision and debridement as well as antibiotics.
Okay. 32-year Pramigavit woman comes to the physician at 30 weeks of gestation and 10-day history of decreased appetite, intermittent nausea, generalized itching. She has no history of serious illness and her pregnancy has otherwise uncomplicated. Her pulse is 98 per minute regular, blood pressure is 104 by 64. Examination show excoriation of the left shoulder. Excoriation of the left shoulder, lungs are clear to auscultation. A grade 2 by 6 murmur is heard based on the left sternal border. The uterus is consistent with size at 30 weeks of gestation. Labs show hemoglobin 11, MCV 86, leukocyte 10,200, red cell distribution were 13%. Total bilirubin 2.1, ALP 206, ASTLT is normal. Abdominal ultrasonography show no abnormality. Which of the following is the most likely explanation of our symptoms? Platelet count is low. Sorry. Platelet count. Okay.
I feel like it's mastocytosis for some reason. Okay. Um, Intrahepatic cholestasis. Intrahepatic cholestasis, also known as cholestasis of pregnancies, is a common liver disease in pregnancy. It typically occurs in the late second and third trimesters and quickly resolves following delivery. Rising estrogen and progesterone concentrations, in addition to potential genetic susceptibility, are hypothesized to result in impaired bile flow. Patients typically present with generalized pruritus and can also exhibit right upper quadrant pain and nausea. Physical exam usually shows excoriations from generalized scratching and possible jaundice depending on the severity. Results of lab studies typically show increased serum bile acid concentration and abnormal liver, here is normal, LFTs. Increased alphos and bilirubin concentration are common, and hepatic aminotransferase activity may also be abnormal. Also, deoxycholic acid is often administered to relieve the itchiness and to prevent neonatal complications related to maternal bile acid crossing the placenta, preterm birth, NRDS, meconium stain amniotic fluid, and intrauterine device. It is not the mastocytosis. Is a rare disorder that of mast cell proliferation in the skin or other organs. In cutaneous mastocytosis, lesions can manifest as itchy maculopapular or urticaria rash. In systemic mastocytosis, mast cells can also invade the bone marrow, liver, and GIT. Therefore, it can present with cytopenias, portal hypertension, and nausea. Serum tryptase activity is typically increased. This patient has no specific skin lesions other than excoriation. It's not normal pregnancy is not characterized by pruritus or nausea in the third trimester, though nausea is an early symptom in pregnancy. This patient also has a typical high bilirubin concentration. Normal pregnancy maternal pulse activity can be increased by placental isoenzyme activity. Additionally, plasma volume increases in late pregnancy, resulting in systolic flow murmur and delusional thrombocytopenia and anemia. But bilirubin is not increased. Okay, next.
Well, it, a 21-year-old woman comes to the physician because of 2-month history of small amount of vaginal discharge. Small amount of vaginal discharge and itching. Her symptoms begin immediately before her last menstrual period. She has 2 sexual partners over the past 2 months and uses oral contraceptive. 1 month ago, she had pain on urination. She had pain on urination unit frequency that resolved after 7-day course of cephalexin. Examination shows a red introitus and vulva. Examination shows a red introitus and vulva. They are erythematous vaginal walls with a normal amount of vaginal discharge. The cervix and the cervical discharge are normal. Vaginal pH is 4.5. The addition of KOH to the discharge produce no odor. A wet mount preparation show no motile organism. Which of the following is the most likely causal organism? Is it like normal vaginal flora after
What do you mean?
she is on antibiotic? She was on antibiotic 1 month ago.
There's not. There is no answer that says my normal vagina flow.
Like not like okay.
Cannot be. She was on cephalexin. Cephalexin is part of the ceftriaxone and all that, right?
Yes.
Mm, Okay, ready?
Yes.
Oh, damn it. The patients presenting signs and symptoms of vaginal pruritus, vulvar redness, odorless discharge on KOH testing are suggestive of vulvovaginitis, vulvovaginitis from Candida albicans. Okay. While Candida species compose an element of normal vaginal flora, overgrowth can occur and lead to vulvovaginitis. Candida albicans is the most frequent associated species. Candida is a cause of vulvovaginitis, can be distinguished from other potential causes by abnormal white vaginal discharge with normal vaginal pH. Oh, it's the pH. Negative KOH testing and absence of motile organism on wet mouth. These factors for Candida vulvaginitis include the use of medication, especially antibiotics and oral contraceptive, use of intravaginal or intrauterine contraceptive devices, and use in immunocompromised state. Candida vulvaginitis is treated with intravaginal antifungal agents such as cotrimazole, miconazole, and nystatin, or with oral fluconazole. It's not B. chlamydia, where is B? It's a STI that most commonly presents in women with cervicitis. If untreated, it may progress to PID. It typically manifests with a thin watery discharge and with cervical motion. Then, although patients may also be asymptomatic, the absence of cervicitis in this patient It's the key. And it's not D, Neisseria, gram-negative. Diclococcal can present with cervicitis, PID, feet scots, disseminated gonorrhea, septic arthritis, urethritis. When causing vaginitis, Nosea gonorrhea typically presents with mucopurulent and discharge and pruritus. Although patients may be asymptomatic, the absence of abnormal mucopurulent and cervical discharge suggests that infection with Neisseria is less likely. What were the pHs again for
Vaginal
Candida? For
pH,
it was uh-huh.
sorry, 4.5,
For which one?
like
It
for
was Candida, Trichomonas, and then another one that had the Gardnerella.
Gardnerella and Trichomonas, maybe it has more than 4.5. Okay, I, okay, I try to say that.
Huh?
Okay,
Sorry.
okay, I'm uh, seeing from the first state.
Um,
Tricho-
okay, so it is Candida do not change the vaginal pH. It cannot grow on the 4.
Okay, Candida, bacterial vaginosis and Candida is 4.5. Sorry, bacterial vaginosis and Trichomonas vaginitis. These two has pH more than 4.5. You got it? Okay, I'm
Yeah.
sharing my screen. You can
Yeah,
see.
I got it. More than
So
4.5.
bacterial vaginosis and Trichomonas has a pH more than 4.5, and Candida pH is normal 4 to 4.5. Normal vaginal pH is 4 to 4.5. Okay,
Normal vagina is 4 to 4.5. And here the pH was 4.5.
5. So within the normal limit,
Mhm.
they actually in this question I think that as she is on antibiotic, so as due to antibiotic her normal vaginal flora cause causing this infection.
Mhm.
Okay.
Okay. Next.
A 50-year-old woman, gravida 3, Baradu, aborta 1, and he has a loss of urine with coughing and straining and lifting since the birth of her child 9 years ago. The symptom has progressively worsened over the past 2 years. During examination she loses urine in small spurts with coughing. She loses urine in small spurts with coughing. But the anterior and the posterior vaginal wall appear well supported. A cotton-tipped applicator is placed in the urethra, in in an arch of 45 degrees with the horizontal during the Valsalva maneuver. Which of the following is the most likely diagnosis? Uh,
Ready?
okay,
Urethral. Stress urinary incontinence is common in multiparous women. Multiple pregnancies with resultant mechanical stress on the vaginal wall and pelvic floor can cause weakness of the muscles and connective tissues and of the pelvic floor. This weakness in turn compromises support of the pelvic structures, including the uterus, bladder, and urethra and rectum. Urethroceal occurs when the urethra prolapses into the anterior vaginal wall. Is the urethra okay? Anterior vaginal wall or out of the urethral opening itself due to the loss of proximal support. Increased abdominal pressure causes the vesicourethral junction to move out of place, preventing sphincter closure with the subsequent leakage of urine. It is associated with urethral hypermobility as evidenced by deviation greater than 30 degrees from horizontal um, of an inserted cotton tip applicator with straining. It can occur alone or in conjunction with cystocele and is a common cause of stress incontinence.
Why it is not cystocele?
The cystocele is common in multiparous women due to weakness of pelvic floor, which causes the bladder to prolapse into the anterior vaginal wall. Cystoceles are associated with stress urinary incontinence, but they can also cause urinary retention or incomplete bladder emptying. Physical exam most commonly shows a bulge in the anterior vaginal wall, and urethral hypermobility is absent.
Bulge in the. Then how we can figure it out? Like what is the difference between cystocele versus erythrocyte according to this stem?
Cystocele, I guess you will see a bulge. What is it? And then urethrocyte, you won't see a bulge. You will just see hypermobility. I don't know why this one doesn't show.
In erythrocyte,
In urethrocyte, yeah, you will just see
like
hypermobility.
this cotton tip applicator, what does it mean?
We saw it somewhere. Was it? There was a question. I don't remember if it was you or, but it was explaining it like the cotton tip thing. I don't remember, but it was like a.
Like if we place the cotton tip through the urethra, then it will.
Yeah, yeah, and if it bends like to I don't know how many degrees, that means that there is like stress urinary incontinence or something like that.
Okay.
Yeah. But yeah, the bladder you see when it prolapses to there will be that bulge right here.
What is the main clue in this question? Like you are
The main clue is the cotton tip here in the question.
the cotton tip applicator. It is for
Yeah.
erythrocyte, not for cystocele.
I don't think yeah
Okay.
you will see that in cystocele. And then the fact that there is no bulge, you can also no bulge in the anterior wall. And then the fact maybe that there is also no urine the way they say that if with cystocele you will have urine not incontinence, the urine will be retained in the bladder.
Okay.
Mhm.
Next. A 42-year-old woman with SLE comes to the physician for follow-up examination. 2 weeks ago, prednisolone therapy was begun because of a flare of her disease. This is her third course of prednisolone during the past 18 months. Today, the patient is feeling well, mens occurs at regular 28 days of interval. Her only medication are vitamin D and calcium. She has no other history of serious illness. There is no family history of serious illness. She had no allergies. She doesn't smoke or cigarette or drink alcohol. She is 5 feet 5 inch tall, weight 63 kg, BMI 23 kg per meter square, pulse 70, blood pressure 108 by 64. Examination shows no abnormalities. Which of the following is the most appropriate pharmacotherapy to prevent osteoporosis?
Ready?
Yes.
Um, it's alendronate now. Steroids, glucocorticoids significantly alter calcium metabolism by decreasing GI calcium absorption, enhancing osteoclast, and inhibiting osteoblasts. Primary prevention of osteoporosis is indicated in patients with chronic steroid use to prevent premature pathologic fragility fractures. Vitamin D and calcium are recommended for all patients at low risk of fractures. In addition to calcium and vitamin D, patients at moderate to high risk of fractures are also treated with oral bisphosphonates like calendronate. Bisphosphonates have been shown to reduce fracture risk and increase bone density. They are the mainstay of osteoporosis treatment and prevention in patients that are at moderate to high risk of bone mineral density loss because of steroids. Bisphosphonates act to inhibit the action of osteoclast, thereby preventing bone loss. Not calcitonin, because calcitonin is a peptide hormone that decreases osteoclast activity and osteoclast differentiation, thereby reducing bone resorption. However, it's significantly less effective than bisphosphonate. It is therefore not the first line treatment for osteoporosis or prevention of steroid-induced bone loss. And it's not, what is it? Traloxifene is a SERM that acts as an estrogen agonist in the bone and an antagonist in the breast and endometrial tissue. It may be used for prevention of osteoporosis in women at high risk for breast cancer. Okay. However, it carries an increased risk for DVT. Okay. Therefore, it's not ideal in a patient predisposed to thrombosis due to a non-inflammatory state like lupus. Okay, and at risk of antiphospholipid syndrome. Okay, next.
Okay, 47-year-old non-gravid woman comes to the physician because of heavy menstrual flow during the first 3 months. Previous means were normal with regard to flow. She has a mild hypertension treated with diuretics, type 2 diabetes mellitus treated with oral hypoglycemic. She has no history of abnormal pap test. She is 5 feet 3 inch tall, weighs 95 kg, BMI 37 kg per meter square. Her blood pressure is 146 by 86. Physical examination shows no other abnormalities. A pap smear is reported with atypical glandular cell. Atypical glandular cell colposcopy shows no abnormality. Endocervical curetes show benign cell. Which of the following is the most appropriate next step?
Ready?
Yes.
Endometrial biopsy. Abnormal uterine bleeding (AUB) should be suspected when bleeding is irregular, unpredictable, and not associated with usual menstrual signs and symptoms like bloating, restfulness, uterine cramps. It may be caused by structural abnormalities such as cervical endometrial polyps, adenomyosis, endometrial hyperplasia, malignancy, inflammation, infection of the GI tract, genital tract, coagulopathy, ovulatory dysfunction, endocrine dysfunction like thyroid disorders, prolactin, androgens. It may also be iatrogenic or idiopathic. The patient has no symptoms or history of thyroid disease, coagulopathy, PCOS, or ovulatory dysfunction. In patients over 45 of age, there is a higher risk of endometrial hyperplasia and malignancy. The patient has a typical glandular cells on pap smear and has been evaluated for cervical malignancy with colposcopy and endocervical curettage, which were normal. The next appropriate step is evaluation will be endometrial biopsy to evaluate for risk of endometrial cancer. If a patient cannot tolerate an outpatient procedure or if the outpatient sampling of is non-diagnostic, a dilation and curettage or hysteroscopy can be performed. A hysteroscopy with sampling allows for a more complete evaluation of the endometrial polyps, myomas, structural abnormalities. Second pap smear in 6 months will not be the appropriate next step because pap smear already shows atypical glandular cells. Repeat pap smear and cytology will be the next step in management for women with atypical squamous cells of undetermined significance. For women with atypical squamous cells of undetermined significance, another option would be HPV DNA testing. If HPV is detected, colposcopy is the next appropriate step. If HPV is not detected, a repeat pap smear is done in 12 months. It's not pelvic ultrasound can be helpful in evaluating endometrial hyperplasia, polyps, myomas, and other structural abnormalities of the uterus. Endometrial thickness of greater than 4 in a postmenopausal patient, a polypoid mass or fluid collection is indication for further evaluation and sampling. Given the presence of glandular cells on sampling, the best next step would be a biopsy to evaluate the cause of the atypical cells. And lip of the cervical transformation zone will be done in colposcopy or endocervical curvature show or cervical cause of the typical pap smear findings. Okay, next. Hello?
Yes,
Oh,
a 37-year-old woman, gravida 1, para 1 with recently breast cancer, comes to the physician for advice of regarding contraception. She will begin chemotherapy and radiation therapy in 6 weeks. She had been using oral contraceptives for 3 years. She has been using combined OCP for 3 years, but discontinued it 8 weeks ago on advice on oncologist and began using condoms. Since discontinuing OCP, she had one menstrual period and lasted for 4 days previously. Means occurred at regular interval. 28 days interval lasts for 3 to 4 days. She delivered her first child 18 months ago. Wishes to have another child in future. She has no other history of serious illness, takes no other medication. Her blood pressure is 115/72. PAP of LB examination shows no abnormalities. Which of the following is the most appropriate recommendation regarding contraception for this patient?
hmm.
So we can give the combined OCP like estrogen therapy.
We cannot, or we can. What do you say?
We cannot,
Okay.
isn't it?
No, yeah, we cannot. She has breast cancer.
So we cannot give her hormone therapy, isn't it?
I guess not. I guess even if we give, you have to be just progesterone. But yeah, no, I don't think hormone therapy. We cannot give her.
Okay, let's place a copper right.
Mm. Okay, so it's placement of copper IUD. Placement of copper IUD is a long-acting reversible contraceptive option that can be used in patients with breast malignancy. Breast cancer may express estrogen, progesterone, or HER2 receptor positivity. Okay. Depending on the receptor positivity of the patient breast malignancy, hormonal contraceptive may be harmful and increase the risk of breast cancer progression. Copper IUD provides a contraceptive method without the use of hormone. Copper is spermicidal and inhibits sperm motility and the acrosomal reaction necessary for fertilization, as well as induces local inflammatory changes on the endometrium and increases cervical mucus production, further decreasing the chance of the sperm passage and implantation. The IUD can be kept in place for up to 10 years, and the rate of pregnancy is less than 1%. Potential complications include increased menstrual flow, and pain during menses. Contraindications to copper IUD insertion include copper allergy, Wilson disease, endometrial cancer, and undiagnosed abnormal uterine bleeding. And we know it's not progestin, it's not medroxy, whatever. And diaphragm. A diaphragm is a barrier contraceptive that it fits on top of the cervix and anterior wall of the vagina. It must be placed prior to intercourse and left in for 6 to 8 hours after use. It is typically used with spermicide. A diaphragm is not as effective as preventing pregnancy compared to IUD. It also carries an increased risk of UTI due to pressure on the urethra and use of the spermicide, which will be unsuitable in a patient undergoing immunosuppressive therapy with chemo and radiation. I don't
Okay.
understand. So is it
What?
like, is hormonal?
Sorry.
Is it hormonal, the diaphragm?
What
The
is
this
mono?
is it hormonal? Sorry, does it have hormones, the diaphragm thingy? Is it
I don't know about that diaphragm truly.
oh,
Maybe maybe it is hormones so because it is unsuitable in a patient undergoing
okay.
immunosuppressive therapy. You can see. I
Okay.
don't know actually.
I don't
I
know.
don't have any idea of the diaphragm.
Okay, but it says must be placed prior to intercourse and then remove it. So it's just like it's not permanent thing. It's just you put it and
It's
you take
just
it out.
yes.
Okay. Next.
Okay, can we take a 5 minute break? I'm coming.
Yeah. Yeah.
My brain is not working. Okay, I'm
No worries.
okay.
Me too.
A 37-year-old, 37 weeks gestation, 28-year-old woman with gestational diabetes delivers 4.5 kg newborn who develops hyaline membrane disease. The mother has postprandial serum glucose concentration 180 by 200 milligram per deciliter. During the last half of the pregnancy, the macrosomia and the pulmonary disease are most closely related to increased serum concentration. Which of the increased serum concentration of which of the following fetus?
Oh, my pen.
Yes,
Ready?
yes.
So it's insulin. Excessive fetal exposure to insulin. Uh, Excessive fetal exposure to insulin in utero can cause microsomia and hyaline membrane disease, also called NRDS. HPL, human placental lactogen produced by placenta, increases maternal insulin resistance. Gestational diabetes occurs when the mother's body cannot generate enough insulin to overcome the insulin resistance. This leads to increased concentration of glucose in the mom circulation and subsequently fetal circulation. Fetal hyperglycemia in turn causes the fetus to produce excess insulin. The insulin then acts as a growth factor, leading to microsomia. Oh. The insulin also inhibits the production of surfactant, and this relative deficiency leads to increased alveolar surface tension, alveolar collapse, and hyaline membrane disease marked by fetal respiratory distress, hypoxia, rhonchi auscultation, and diffuse alveolar infiltration imaging. Risk factors for gestational diabetes includes obesity, PCOS, previous gestational diabetes, and African American, Asian, Hispanic, Native American, and Pacific Islander. Okay, let me understand. So the HPL causes insulin
Increased resistance.
insulin resistance in the mom. So the mom gets diabetes, a lot of glucose. The glucose goes to the baby. Then the baby starts producing a lot of insulin. And it's that insulin that is causing the macrosoma, the
Insulin
macro
causes the growth factor to release, which leads to macrosomia.
insulin causes growth factor to release, which leads to microsomia, and insulin also causes the NRDS. Okay. So HPL is a hormone produced by the placenta that increases maternal insulin resistance. It continues to rise throughout pregnancy, peaking just before birth. It plays a role in the development of gestational diabetes, but it does not directly cause the microsomia. Hmm, okay, it's important to know. Okay, next.
So if they told us like, if it is like, if they ask about the which placental hormone increases, then HPL, HPL actually causing maternal insulin. Okay,
Oh, okay,
next.
next.
A 26-year-old newly-gravid woman had an infertility 2 years ago. Means occur at regular 25-day interval. Serum progesterone concentration 8 on menstrual day of 21. An endometrial biopsy specimen show oh, an endometrial biopsy specimen show on menstrual day 24 is most likely show which of the following in this patient.
Progesterone is normal. Menstrual day 24. Okay, ready?
Yes.
Secretory endometrium. Secretory endometrium occurs during the luteal phase of menstrual cycle or the 14 days prior to menstruation. The first half of the menstrual cycle is the follicular phase, which varies in length and begins with the menses. During menses, FSH and LH concentrations increase and stimulates the developing follicle. The follicle produces estrogen, which leads to proliferation of the endometrium in preparation for implantation of a fertilized ovum. As estrogen rises, a surge occurs, which in turn stimulates a surge in LH that causes ovulation. Immediately following ovulation, the luteal phase begins. Follicular phase, luteal phase. The luteal phase begins as the corpus luteum forms. The corpus luteum secretes progesterone to maintain the endometrial lining. If no implantation occurs, the corpus luteum degrades to the corpus albicans, and estrogen and progesterone concentration decrease, causing menstruation and minor increases in FSH and LH. Since the patient progesterone is within the reference range, and the biopsy is occurring 4 days before her regular expected menstrual period, the biopsy will most likely show secretory endometrium. It is not atrophic endometrium refers to decrease in the normal
I
amount
don't
of
understand. Can you please explain, like, when the proliferative endometrium, when the secretory endometrium, when so it
I
is
think
okay.
Mhm. Go
You
ahead.
tell me.
I think for proliferative is during the follicular phase, and then secretory is during the luteal phase.
And how will I do this timeline? Like, what is the key point in this question you found? Why you choose secretary endometrium?
Well, first I just guessed. I guess I just guessed. I didn't really. There was no key thing for me. But so yeah,
Like, isn't any timeline like endometrial biopsies specimen on menstrual day 24 is most likely to show?
they
Like
are saying on the
the
thing that it's 14. The first 14 days. So once the um first 14 days is follicular phase,
okay,
and the next 14 days is luteal phase. So first 14 days is follicular phase with proliferative endometrium,
okay,
and next 14 days is luteal phase with secretory
secretary
endometrium.
endometrium. Okay,
That would be
so
the first way to see it. And she is in the
24th day
24th day, so it will be what
secretary
is it?
endometrium. Okay,
Luteal phase with secretory endometrium. And it's not atrophic endometrium refers to decrease in the normal amount of endometrial tissue. Commonly seen in postmenopausal women because of decrease in estrogen. This patient is still having regular periods, making atrophic endometrium unlikely in biopsy. Okay. Oh, wait, let me see. Decidual endometrium. What is it? Decidual endometrium forms from the endometrium following implantation of the embryo. It's stimulated by progesterone and forms the maternal part of the placenta. As this patient is not pregnant. Okay, got it. Sorry. Next.
a 47-year-old woman has an increasing fatigue, constipation, night sweat, anxiety, mood lability over the past year. She has had 2.3 kg weight gain during this period. Her last menstrual period was 6 months ago. Her last menstrual period was 6 months ago. BP 130 over 80. Pelvic examination shows no abnormality. Which of the following is the serum concentration is most likely to be increased? Does she have weight gain in this last menstrual period? What is your diagnosis?
I have no diagnosis here. I guess it's something with the thyroid. Stimulating fatigue, constipation, night sweats. And it
Like
smells sweet.
hypothyroid causing this uh, late menstruation. Her last menstrual period was 6 months ago.
Yeah, it's hypothyroidism. So what will be increased? Both TSH and TRH will be increased. So I don't know.
Hmm, what the
Because both of them will be increased.
so
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 maybe it's
why
not
so it may be another thing.
probably another thing. Is it cortisol? I feel like cortisol will have I don't know. This doesn't make sense. I feel like it's ACTH, but I don't know why ACTH.
Thinking that way, like she's 47-year old, so he's in the verge of he's in the he's at the end of the menstruation, isn't it? That's
Hmm.
why her menstruation is so late.
So you think it's FSH that will be increased?
Because both TSH and TRH does not make sense.
It doesn't make sense. The only thing that you think is menopause is getting close to menopause. Okay, menopause will explain the mood, but I don't think it will explain the weight gain and the constipation. And maybe it will explain the night sweats. It will explain that. But it's just too much. I don't
Okay,
know. Big one. I don't know. Oh, you were right. It's menopause. Damn. I didn't even know menopause would cause all that. Okay. Is FSH begins
The
to
two
increase.
answer does not make sense, like
Yeah,
TSH and TRH.
follicle stimulated hormone begins to increase with the start of menopause. While menopause is defined by the absence of menstruation for 12 months, symptoms can begin prior to menstrual cessation. It primarily presents, in women 40 to 50, but premature menopause can occur in women less than 50, 40, especially in those who smoke. Common symptoms include hot flashes, night sweats, irritability, mood changes, vaginal atrophy, loss of libido. Menopause occurs secondary to exhaustion of ovarian follicles with subsequent anovulation and decreased estrogen concentration. In response, FSH and LH lack negative feedback and are increased in the serum. Menopause is often clinical diagnosis, but these lab values may be obtained if diagnosis is unclear. Hormone therapy or SSRIs, SNRIs can be used to prevent the vasomotor symptoms of menopause, but hormone therapy has been attributed to an increased risk of breast cancer, hypercoagulability, and cardiovascular mortality. It is, can you hear me?
Yes.
Okay. Oops.
27-year-old primary gravid. Okay. 27-year-old primary gravid woman.
Where are you? Oh, right here. Sorry.
Yes, yes. 27-year-old primary gravid. Oh, sorry. 27-year-old primary gravid woman and 19 weeks of gestation comes for a routine prenatal visit. She works in a preschool. Pregnancy has been uncomplicated except for mild gestational symptoms. 6 weeks ago, she has an abnormal triple screen study. She has an abnormal triple screen study prompting ultrasonography that shows fetal hydrops and ascites. For which of the fetus or newborn or with abnormalities? Select the maternal condition likely associated with this condition. Okay.
Okay.
Yes.
Oh, what is it? 20 is Parvo B19. When acquired, um, when acquired while pregnant, typically presents with a mild viral syndrome that may include fever, chills, headache, myalgia, arthralgia, nausea, vomiting, abdominal cramping, diarrhea, or respiratory symptoms. Generally self-resolving and seldom carries a burden of morbidity in otherwise healthy patients. However, there may be consequences of maternal parvovirus B19 infections for the fetus, especially if the infection is acquired in the second or third trimester. Parvo B19 has tropism for bone marrow where it infects red blood cell progenitors, causing fetal anemia, which may present as fetal tachycardia, high drops, high output heart failures, and death. It can also cause fetal myocarditis. This mother risk for fit factor for parvo B19 occurs from exposure in a preschool when it is where it's a common cause of childhood erythema infectiosum. Okay, next.
A 19-year-old primary gravid 90-year-old primary gravid woman comes to the emergency department because of vaginal bleeding, abdominal pain, lethargy for 4 hours. She has no prenatal care. She is unable to give a family history. She is unable to give a family history. Her pulse is 112 per minute, respiration is 18 per minute, blood pressure is 190 uh, over 108 millimeter of mercury. Abdominal examination show fundal height 27 centimeter. The abdomen is rigid and tender to palpation. Abdomen is rigid and tender to palpation for which of the following? For each patient with a fetus and a newborn with abnormalities, select the maternal condition most likely associated with these diseases.
Ready?
1 minute. Okay.
It is, what is it? Did I pass it? No. Cocaine use. Cocaine use in pregnancy is associated with placental abruption, the premature separation of placenta from the uterus. Abruption placenta presents with vaginal bleeding, severe uterine pain, and tetanic contractions, typically in the third trimester. It commonly results from lower abdominal trauma, smoking, or cocaine use. In cases of cocaine use, patients typically present with symptomatic toxicity, evidence on vital signs by hypertension, tachycardia. Oh, she has hypertension. Okay, and tachypnea. The uterus is typically exquisitely tender to palpate. It may present similarly to peritonitis, with severe pain disproportionate to exam findings, and abdominal rigidity because of the compromised fetal blood supply. This is an obstetric emergency. In addition to supportive care and fluid resuscitation, treatment includes emergency C-section and Rhd immune globulin if the maternal blood type is Rh negative. It's not cigarette smoking increases the risk of premature birth and low birth weight and has been associated with neurocognitive and behavioral developmental abnormalities. It is also associated with an increased risk of placental abortion, although will not cause hypertension, marking cocaine, making cocaine use more likely in this patient. Yeah, that's it. You know what I did? Not yesterday, the day before. I took a CMS,
Mm,
but I timed myself because I told my tutor that I'm doing good on the CMS, but like I'm getting less than 15. I think you're supposed to get less than 15 questions, less than 15 mistakes. So I told him I'm doing good. The only issue I'm having, I'm running out of time. Like
okay.
I keep running out of, like I keep having like five, six questions that I cannot get to. And he told me that why don't I time myself? Like 1 minute, like give myself 1 minute per question. So
Okay.
I found that this clock online where you can, set it like it's a stopwatch. So every time you get 1 minute, it will sound beep beep beep, and then the 1 minute will start again, and then it will beep beep beep. So I did that. I took a CMS. It was psych. So I
Mm,
took it yesterday, and it really forced you to think fast because you're like once the beep beep beep, you just have to pick an answer. So I ended up finishing on time. I actually had like 11 minutes left. um, that I finished the CMS on time and I had like 11 minutes left to go over, whatever. I didn't go over anything, but, it was just to time myself. I think it helped, if you,
like 1 minute per question.
1 minute I mean, I know the actual exam is like 1 minute and 5 seconds or something, but he just told me since you're having issues, just do 1 minute per question. So as soon as you see that you hear the beep beep beep, you just have to pick an answer and move on. You cannot, you know. So then again, it was psych. So psych doesn't have a lot of those long lab things. So maybe that's why I was also able to do it. But it really like your mind is like once you hear that beep beep beep, you just pick something and move on. Because if you don't move on, then the next 1 minute starts, and then you have less time for your next question. That
Okay.
was the thing. Yeah.
Okay.
So
It may. It might help.
it helped because I was able, and then at the end I was left with like 11 minutes. So then you have time. If you mark, because on the actual exam you can mark. On that one I couldn't mark, but on the actual exam you
Like
can mark.
which watch you were using.
I would send it to you. I found a better one, but I'll send you both, and you just use the one that
Like
you know.
it will be after 1 minute.
It will beep after. Let me forward it to you right now. It will be after 1 minute. It will beep. You can choose the kind of beep that you want. I just chose whatever, but you can choose the kind of beep that you want, and then it will start over. The 1 minute will start over, and then it will beep again, and then the 1 minute will start. They will beep again. Um, so yeah, you can do that and just take it. But then again, I think it also helped that it was psych, so they were not because I know I have a problem when the lab thing is
No,
like
you were
super.
you were good at psych.
Yeah, no,
You are
and I know my issue is, those long labs when where there is like sodium and
yes,
potassium and
yes.
that.
And what
Always. So
happens sometimes, like uh, you read all the options.
hmm
Sometimes you need to skip. Like if you are thinking that this is not, what can I say? This is not important. Then just skip
hmm
it. You
hmm
don't need all the labs. You got my point. What I'm trying to mean.
Oh, yeah, I get what you
And
said.
another thing uh, you try to do, like you need to remember some of the important stuffs.
You told me that I do.
you
I
you
mean,
you got you found the importance, because if you start finding, it will take 1 to 2 minutes.
it takes time. That's why I'm saying that I know that is my problem. When those long labs,
When the long lap comes, you start looking for
I,
the hematocrit and this and that.
yeah,
I
yeah, and they
hardly
take more
see
time. So
those things, but because I try to, like when I do the questions with you, I try to memorize. I know I am not good at memorizing on that things, but I try to.
yeah, I try. I mean, the common ones like sodium and what I can, but when it start getting to like phosphorus and all these things, I'm like, oh shoot, no,
But
I have
we
to do it.
need to keep in memory of those things too, because these are comings, like there are some questions of phosphatemia, hyperphosphatemia, these and that,
Yeah.
magnesemia.
Yeah.
So
So that's why I'm thinking maybe that also helped because it was a CMS for psych, so there weren't that many labs. So maybe that I'm gonna try to do another one, but for like I don't know, surgery or something where I know that there are labs, and see if I can still do like I can still do
do the one block of surgery. It has lots of
surgery.
like cardiology and other stuff
Yeah.
too.
So I'm gonna see if I can still do it, like do 1 minute. But I know in the real exam it's probably like a minute and 5 seconds or something. But I don't know. But yeah, I think it helped at least, because
Yes,
your mind started just like reading faster because okay, you feel like okay, it's gonna beep soon, so you just started reading faster. But yeah, anyway,
okay.
next.
I got your online link. Thank you.
Mm.
Okay, okay. I'm reading the question. I sometimes forgot that I am reading the question. Okay. A 38 year A 38-year-old woman, gravida 3, para 1, aorta 1, admitted to the hospital of 33 weeks of gestation. 33 weeks of gestation because of suspected pyelonephritis, as evidenced by temperature 102, back pain. She has had costovertebral angle tenderness 10. She has had costovertebral angle tenderness for 10 days. Mild contraction for 4 years. IV ampicillin therapy is started. Immune analysis Urine analysis is consistent with UTI. The fetal heart rate pattern is shown. Which of the following is most likely diagnosis? Tachycardia, isn't it?
Yeah, I'm sorry.
But it's,
Ready?
yes.
Is maternal fever. Maternal fever can cause fetal tachycardia, which is defined a fetal heart rate greater than 160. I think the normal is 110 to 160. Other causes of fetal tachycardia include hypoxia and fetal anemia. Conversely, bradycardia is defined as fetal heart rate less than 110 and can be caused by congenital heart abnormalities, as well as hypoxia and fetal distress. Decrease variability in the fetal heart rate tracing also indicates fetal distress. Given this patient presentation, it's most likely that the fetal tachycardia is secondary to the maternal fever, as there are no other signs symptoms suggest fetal hypoxia or anemia. Mm.
Okay. A 62-year-old woman comes to the physician because of two episodes of vaginal bleeding during the past 3 weeks. Menopause occurs 12 years ago. She has hypertension treated with AC inhibitors and type 2 diabetes mellitus treated with oral hypoglycemic agent. She has no history of abnormal annual pap smear. She is 5 feet 4 inch tall, weight 66 kg, BMI 25 kg per meter square. Pelvic examination shows a normal cervix and uterus with blood at the cervical os. A 6 into 8 centimeter left ovarian mass is palpated. Pelvic ultrasonography confirms the results of physical examination. An endometrial biopsy specimen shows atypical complex hyperplasia. Atypical complex hyperplasia, which of the following is the most likely diagnosis? Okay,
Okay. The answer is what is it? Granulosa cell tumor. Vaginal bleeding in a postmenopausal woman show raise suspicion for malignancy, including uterine and ovarian cancer. Ovarian sex-scored stromal tumors are a group of neoplasm which may secrete sex hormone, including estrogen and testosterone. Granulosa cell tumors are the most common sex-scored stromal tumors and present with adnexal mass and evidence of estrogen excess, such as breast tenderness and uterine bleeding. Estrogen excess is a known risk factor for atypical endometrial hyperplasia and endometrial cancer. In the case of granulosa cell tumor, ultrasound may reveal a large complex ovarian mass which may contain septations or cysts. Histological diagnosis is made by biopsy. Identification of calyx nerve bodies is considered pathognomonic. Granulosa cell tumor is treated with surgical resection and may require chemo in advanced cases. Is not Brenner tumor are a rare tumor derived from ovarian transitional epithelial cells. Presenting findings include an anesal mass with a tan to yellow firm gross appearance and cell containing nuclei with grooves on light microscopy. Brenner tumors are not hormone secreting and are less likely to present with atypical vaginal bleeding in postmenopausal women, and it's not E-sertolic lytic tumors. These are sex-cord stromal tumor derived from testosterone secreting sertoli cells. Patients typically had present at younger age and may develop signs of androgen excess as masculinization. Okay, next.
okay. What is the key point you found in this option for diagnosing granulosa cell tumor?
Oh, the endometrium is growing, is hyperplastic, so it must be that the tumor is secreting estrogen. And I knew it wasn't sertolic lady because that's testosterone.
Testosterone.
And I
Then what
didn't,
feature will come if it is sartolytic?
the testosterone probably like, like the hair everywhere or what else?
Okay.
What else?
Andro
Masculinization, maybe.
masculinization. Yes.
Yeah, maybe the voice or things like that. I don't know.
And in
But
granulosa cell tumor, like endometrium is going in the form of like what is atypical complex hyperplasia, this one or
I
the
just looked at the hyperplasia. The atypical complex, I don't know. It was just endometrial hyperplasia. So the endometrial is growing. So it's estrogen. That is XX
oh,
estrogen. The
okay,
atypical, I don't know what that means. And then the ovarian fibroma, of course, there's no hormones there. Ovarian cancer, there is no hormones then. And brennectomy, I just didn't remember what it was.
okay.
Yeah.
Next, 28 28-year-old woman, gravida 1 para 1, has been amneric. Uh, Gravity 1 Para 1 has been amneric and has had hot flushes for past 6 months. She takes thyroid medication for chronic lymphocytic thyroiditis Hashimoto's disease. After using oral contraceptive for 2 years, she discontinued taking it 3 years ago. After using oral contraceptive for 2 years, she discontinued taking it 3 years ago. Serum studies show FSH 62, estradiol 15. Estradiol is low, TSH is normal, 0.5 to 5, and prolactin may be normal, isn't it? 5 to 20 as far I remember.
Prolactin. You said prolactin?
Yes, isn't it normal?
Right. Yes, normal. And TSH
Is
is
normal too. So it is like low estradiol. And FSH is high. Hmm.
it's high.
So FSH and estradiol is
Um,
which of the following is the most likely cause?
no, high. Prolactin. Oh no. Okay. Ready?
Yes.
Autoimmune ovarian failure. Autoimmune ovarian failure, also known as primary ovarian insufficiency, classically presents in a woman of reproductive age with an ovulation, amenorrhea, and infertility. It can also present with signs of early menopause, such as hot flashes, night sweats, and irregular bleeding. It is caused by autoimmune inflammation and destruction within the ovaries, leading to decrease in estrogen production, diminished follicle reserve, the loss of ovarian stromal cells. FSH and LH are appropriately increased because of the lack of negative feedback from estrogen on the anterior pituitary. It is most often idiopathic, but it's more common in women with karyotype abnormalities or other autoimmune diseases such as Hashimoto's. And it's not, I don't think I'm, yeah, I'm confusing something else. No, that's fine.
Okay. Should I persist? Okay. 35-year-old woman gravida to para 1 with a chronic hypertension and has spontaneous onset of labor 39 weeks of gestation. Spontaneous onset of labor 39 weeks of gestation. After 4 hours of regular contraction and a second stage of 5 minutes, mm, she spontaneously delivered 3.6 kg newborn under epidural anesthesia. Approximately 2 months after separation of the placenta, She develops apnea, cyanosis, severe hypertension. During unsuccessful resuscitation, the patient develops bleeding from the vagina and venipuncture site. Which of the following is the most likely diagnosis? Isn't it fluid embolism?
Kind of thinking between that and septic shock and between those two. Okay, ready?
Yes. Oh, oh,
Is fluid embolism. Amniotic fluid embolism is a rare and potentially fatal complication of childbirth caused by amniotic fluid entering the maternal circulation. It most commonly occurs during delivery or in the immediate postpartum period. It presents with acute onset apnea, cyanosis, and circulatory collapse, um, leading to altered mental status and unconsciousness. It is further associated with diffuse bleeding from venipuncture sites, the vagina, or a C-section delivery incision due to DIC. Signs of fetal distress can also occur if the fetus remains in uterus at the time of occurrence. Vital signs will disclose tachycardia, hypoxia, severe hypotension. The patient can quickly become decompensated into cardiovascular collapse and cardiopulmonary arrest. Treatment is supportive, with patients often require fluids or blood products and mechanical ventilation. Maternal and infant mortality rate is high, and it's not septic shock. Is a term used to refer to decreased organ perfusion that occurs from overwhelming infection. Septic shock is a form of distributic shock and is classically diagnosed with fever, tachycardia, tachypnea, hypotension, and signs of infection on exam, as well as leukocytosis and lactic acidosis. The presentation is less abrupt, hours to days, in comparison to amniotic fluid embolism. Okay, next.
52-year-old woman comes to the physician because of 6-month history of urinary urgency. 6 months history of urinary urgency. She often had a strong urge to vomit, but passes only a small amount of urine. Sometimes she is unable to reach a bathroom. Sometimes she is unable to reach a bathroom quickly enough after feeling the sudden need to vomit. She says she often feels hot at night. She says she often feels hot at night and occasionally during the day. She has not had any other symptoms. She has no history of serious illness, take no medication. Her last menstrual period was 12 months ago. She is sexually active. She is 5 feet 6 inch tall, weight 68 kg, BMI is 24 kg per meter square. Her temperature is 37.1, pulse is 70 per minute, respiration 12 per minute, BP 90 by 50, pelvic examination shows moderate tenderness and vaginal atrophy. The uterus is normal sized. There are no valvular or vaginal or cervical lesions or adnexal mass. The remainder of the examination is normal. Including the rectal examination shows no abnormalities. Test of the stool for occult blood is negative. A wet mount preparation of the vaginal fluid shows numerous leukocytes. Urine culture is negative. Her post-vital residue is 50. Which of the following is most likely underlying cause of these findings?
Mm, 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 hot at night. Ready?
What does she have? Is it like a postmenopausal thing?
I'm thinking between that and UTI.
UTI six
But,
month history of urine urgency.
but
Okay,
yeah, it's six
it
months
is
is
postmenopausal.
um estrogen deficiency is in menopause can cause atrophy and inflammation of the vagina and urethra. Oh, leading to an overactive bladder, urgency, frequency, and urge incontinence. This inflammation can result in leukocytosis within the urine and vaginal fluid in the absence of infection. Hmm. Symptoms of hot flashes and last experiencing a menstrual period 1 year ago and experienced by this patient are consistent with menopause and associated estrogen deficiency. Pelvic exam typically discloses vaginal atrophy and tenderness without other abnormality. In addition to any condition causing UTI, no, urinary tract irritation or inflammation, urge incontinence can also be caused by the trousal muscle spasticity and instability from neurologic injuries like a stroke, neuropathy, trauma, or MS. Treatment options for urge incontinence include bladder training, time voiding and relaxation technique, Kegel exercise, and antimuscarinic medications like oxybutynin. In general, supplemental estrogen are no longer widely recommended due to the increased risk of gynecologic and breast malignancies and DVT. It is not UTI. Urinary tract infection can present with overactive bladder. Patients generally also experience dysuria and suprapubic pain. This patient urine culture was negative, essentially ruling out an infection. Oh, they did urine culture. Oh, right here, urine
Urine
culture
culture
negative.
is negative. Yes.
Oh, I didn't see that. Okay.
Okay. Next, it's asexually active. You haven't scrolled. That's why I said next.
Oh, sorry.
I was watching your screen too, because I sometimes read from your screen. Okay, asexually active. Asexually active. 21-year-old patient. 20, Asexually active 21-year-old college student request an OCP. There is no contraindication based on the medical history. In addition to the PAP, which of the following test is most appropriate? 21. Child.
Feel like it's between.
I'm in between A and D.
I mean, I'm in between. I'm in between A, C, D, E.
Why C?
Because when does the glucose thing start? The screening.
She's not pregnant. When why we do glucose? Like OJT, she has no features. Why we do glucose?
I thought the glucose screening, like,
You have
oh,
done glucose in your life?
yeah.
When?
I thought it was like a screening
No,
one.
never, never.
Oh,
It's not a screening. It's screening
oh,
for the pregnant woman in like in the second or third trimester, like
no, that's the GG, that's the
OGTT.
OGTT. But like there is like for, oh, I know there is a screening for
I
one.
never heard about the glucose.
Okay, then if it's not glucose, then I guess it's either, I guess chlamydia. Then it can be any of them. Okay, I guess
Is
maybe
it
I'm just
either chlamydia or HIV? Okay, I think chlamydia fits well.
probably, yeah, chlamydia.
Like
Oh,
something we have heard, like one time we have to do HIV. Where it is that? If it is STD,
I know what you mean. I don't remember, but I know there was a
yesterday
question
we
where
have
we said,
discussed about this. Maybe
mm,
there is a question. Okay,
I
start
remember, but
reading.
what's the question? Testing for chlamydia as well as Neisseria is recommended by the USPSTF for all sexually active patients under 25 years old. Chlamydia is a STI that classically presents with urethritis, dysuria, urethral and vaginal discharge. However, it can also be asymptomatic. Complications include cervicitis, epididymitis, reactive arthritis, PID, gram stain of the urine, and urethral and vaginal discharge typically does not reveal organism, as chlamydia is an obligate intracellular organism. Diagnosis is made with NAT, and treatment consists of azithromycin and doxycycline in combination with ceftriaxone for Neisseria co-infection. And it's not, what am I? See, measurement of fasting serum glucose concentration is used to diagnose diabetes. Common symptoms include thirst, frequent urination, weight loss, fatigue, and frequent infection. The patient does not have the signs and symptoms of diabetes, and measurement serum glucose concentration is not warranted by the. Yes, okay. So you do it when they have symptoms. Aside for HIV, antibodies to screen for HIV infection may eventually be appropriate as the UST, whatever, and the CDC recommend that everyone between teenage years and 65 be tested at least once. Those at higher risk, men who have sex with men, or those with multiple sex partners, or having sex in exchange of the prostitutes, or having or using condom inconsistently, should be screened more frequently. This patient will benefit from testing for chlamydia at this time as it's more common infection and more frequently presents asymptomatically. Though HIV testing should also be performed, eventually be performed in the future. Syphilis is not recommended in asymptomatic patients. Syphilis has a multitude of presentations depending on its stage. Primary syphilis, genital lesion that is non-painful, while secondary syphilis, maculopapular rash, and condylomata clata. Tertiary syphilis, neurosyphilis, stapes dorsalis, the pupils, and otitis. The patient is not experiencing any symptoms. Okay, next.
Okay. A 28-year-old woman, gravida 3 para 2, 30 weeks of gestation, is brought to the emergency department because of pain of the right mid-abdomen for 12 hours. She has had one episode of diarrhea since that time. Her temperature is 101. Physical examination shows diffuse tenderness on the right lower quadrant of the abdomen with minimal guarding. Rectal and pelvic examination show right-sided tenderness. Her leukocyte count is 14,000 with a shift to the left. Ultrasound of the abdomen shows fluid in the right para-aortic cutter. The appendix cannot be visualized. Which of the following is the next step in the management? Oh,
Yeah, yes,
one
since
sec. Is there any BP or blood pressure required?
no. Minimal guarding.
Ultrasound show
Diarrhea. I don't even know what's the diagnosis.
30 weeks of gestation. Only one episode of diarrhea.
Is it appendicitis?
Appendicitis, most probably.
Doesn't make sense. Then what's the fluid in the what's the paracolic order?
Like appendicular abscess.
Oh, appendicular access. Then do we do
Look
this?
like, looks like, I don't know.
Yeah,
Maybe
makes sense. Makes sense. Okay.
because from where you are giving two answers.
Sorry, no, I wanted to remove that one. I don't know why it's not going away. It's
Is,
not going.
isn't it? Okay,
It's not going away. I don't
okay,
know why.
okay. No problem. I'm just asking.
Surgical exploration. Yeah, it's appendicitis. You were right. Typically presents with right lower quadrant abdominal pain that is often periumbilical at onset, with associated nausea, anorexia, fever, leukocytosis, tenderness to palpation in the right lower quadrant on exam. In pregnancy, due to the location of the enlarging uterus, the appendix may be displaced a little bit up in compared to that of a non-pregnant woman. This displacement limits the classic history and physical exam, which rely on right lower quadrant position of the appendix. For example, initial periumbilical pain is attributed to vague visceral innervation of the appendix being referred to the midline. Once the inflammation affects the parietal peritoneum, the pain becomes well localized to the right lower quadrant, hence the migratory character. McBurney's point, a sensitive location for tenderness on palpation, is located one-third the distance between the inguinal ligament and the umbilicus because this is the common position of the appendix. The displaced cephalad, when displaced cephalad, the parietal peritoneum inflammation may no longer occur at the McBurney point, even migrating as far as the right upper quadrant, mimicking diagnosis of cholecystitis. Diagnosis is facilitated by CT scan, though we don't do it in pregnant women due to risk of their exposure to the fetus. MRI and ultrasound, which may show appendiceal enlargement, the presence of appendicolite and appendiceal wall thickening or periappendiceal fluid. Okay. Fluid in the paracolic gutter is suggestive of appendiceal rupture or perforation and is typically accompanied by fever and leukocytosis. Immediate surgical exploration and appendectomy is indicated to prevent maternal and fetal complications, including peritonitis, sepsis, and death. And it's not C because broad spectrum antibiotic therapy and observation are appropriate treatment options for uncomplicated appendicitis in select patients. This strategy is not appropriate in gravid patients and is associated with lower success rate compared to appendectomy, which remains the standard of care. Surgical exploration is mandatory once appendiceal perforation is suspected or has occurred. Okay, so appendicitis surgery always. Next,
A, pre- a previously healthy 32-year-old woman comes to the physician because of 2-day history of vaginal bleeding and lower abdominal cramps. Her last menstrual period was 7 weeks ago. She is sexually active with one partner and they use condoms for contraception consistently. She takes no medication, pulse is 90, blood pressure 100 by 65. Physical examination shows a soft abdomen and a lower quadrant tenderness. Speculum examination shows moderate vaginal bleeding and closed cervical box. Pregnancy test is positive. Transvaginal ultrasonography shows a fluid-filled endometrial cavity, and no gestational sac. Her quantitative serum beta HCG is 2500 milli international unit per ml. 40 years ago, 48 years later, a second measurement of quantitative beta HCG is 2800 milli international per ml. Which of the following is the most likely diagnosis? Not.
ready?
Oh, wait 1 second. Full cavity, no. Vaginal bleeding and lower abdomen. Okay.
Okay, the answer is ectopic pregnancy. Wow. Pregnancy is suspected when there is a missed or delayed menstrual period. An ectopic pregnancy often presents with vaginal bleeding and abdominal pain. Serum beta hCG is produced by the placenta, is undetectable in non-pregnant patients and doubles approximately every um, 48 hours, so 2 days during an early normal pregnancy. Ectopic pregnancy is an abnormal pregnancy in which the fertilized ovum implants in the fallopian tubes or the ovary within the peritoneal cavity or in any non-endometrial location. Beta hCG concentration does not increase as expected in ectopic pregnancy, often lagging the normal expected doubling. Ultrasound can be used to assess for an intrauterine pregnancy and may show ectopic pregnancy. In a normal pregnancy, an intrauterine gestational sac should be visible by 5 weeks. Additionally, transvaginal ultrasound provides sufficient sensitivity to detect an intrauterine pregnancy once the beta hCG concentration exceeds like 1,000 to 2,000. An ectopic pregnancy is not viable. Treatment of an ectopic pregnancy can be medical with methotrexate for small early pregnancies, but may require salpingectomy or evacuation with laparoscopy for larger pregnancies or in cases of medical treatment failure. Complications of ectopic pregnancy include rupture, bleeding, and hemoperitomia. It is not ABC. What is A? Wait, it's not ABD. Okay. It's not blight ovum, is an embryonic pregnancy in which fertilized eggs attaches to the uterine wall and the gestational sac without an embryo develops. Huh? Fertilized egg
Yes,
attaches to the uterine wall and a gestational sac without an
without
embryo.
an embryo.
It may present with vaginal bleeding or may be asymptomatic and serum beta decreases with time. Wait, so is the egg with no sperm? No,
Yes,
wait. Okay.
fertilizer attached to the uterus. Yes, it is just like a non-pregnant, like if a woman without having like sexual intercourse, he may got like got pregnant. You may feel that he got pregnant. His beta ECG is like sometimes increasing, then it decreases with time. Looks like an embryo. Oh, sorry,
Hmm.
looks like a gestational sac with an embryo. It happens sometimes. Looks
Oh,
like she's pregnant, but actually this is a blighted ovum.
oh. Okay. Complete spontaneous abortion will also present with abdominal pain and vaginal bleeding with a delayed menstruation period. However, beta ECG concentration should decrease, not increase, with the spontaneous abortion. Okay. And hydatidiform is a form of gestational tophaceous disease characterized by non-invasive diffuse swelling of chorionic bile in the absence of fetal parts in the case of complete mole. Complete mole contain purely paternal DNA, and on ultrasound, there may be an enlarged uterus with cystic structures without any specific fetal structures. Identiform mole produce beta hCG often in excess of proportion to gestational dates, which can be used as biomarker. So I guess the beta hCG will be way higher than that.
I-
That's
Yes,
what it means. Okay.
like in here, how you found that this is ectopic pregnancy? How you thought that it is hydatidiform mole, but
No, I thought it was identiform mole.
okay,
Mhm. But they're saying it's not identiform because yeah, it will increase, but it wouldn't just increase to from 2,500 to 2,800. It will increase to like 50,000. It will increase a lot,
okay.
and then there will be cystic masses inside the uterus. But here they had, I saw
No,
something inside the uterus, but I don't know. There was something inside the uterus. That's why I went with identiform. They were
beta
saying something.
ECG actually doubles in the beta ECG is increases in pregnancy too on a normal intrauterine. So it's sorry,
But
it's
here
not.
I saw it was saying that the uterus had fluid filled endometrial cavity. So that's why I thought that they meant like the cystic thing, but I think it's not that. I guess it's not that. Um, I guess ectopic pregnancy, the beta hCG will also increase, but it will increase a little bit. Because here it was supposed to double. It was supposed to be like 5,000 after 48 hours, but it only went to 2,800.
In case of
Um,
normal pregnancy,
yeah, it says it's supposed to double after 2 days. But here it
okay.
only went from, yeah. And it's not complete spontaneous abortion. I forgot why it's not complete spontaneous. Oh, because it should decrease. The beta should decrease. Yeah. Okay. Next.
A 17-year-old girl is brought to the physician. A 17-year-old girl is brought to the physician by her mother her because she has never had a menstrual period. She is otherwise healthy. Both of her older sister had normal pubertal development. Examination shows an absent breast development and a scant pubic hair. Sca- uh, uh, Examination show absent breast development and a scant pubic hair. Her serum FSH concentration is 105. Which of the following is the most appropriate next step? Serum FSH is high, isn't it?
Mm-hmm.
Um, suddenly, no, that's a blast. Is it Turner?
How would you know from the question?
Because absent breast, scant pubic hair, FSH is high, and the girl has no means. Looks like, I don't know,
Okay,
feeling like, feeling
feeling
like.
like.
I'm
Well,
going crazy actually these days.
okay. Yes, it's Turner. Turner syndrome is a common cause of primary amenorrhea, which is caused by ovarian dysgenesis in a 45XO genotype. Other signs
Your
of
one
Turner,
is love marriage, isn't it?
my what?
Like
The
I
what?
ask your personal question. Like,
Wow,
like your one is the love marriage, isn't it?
what does
Like
that
you
mean?
and your husband.
Uh-huh.
Uh, you are like you have love marriage. Like you got my point.
No.
Like, is it arrange or love?
No, it's love. It's not.
You
Sorry, I
okay?
wasn't getting it. I was like, wait, what do you mean? Okay, okay, yeah, it's love.
I don't always want to talk about the studies.
No, no,
Okay,
it's love. I mean, yeah.
okay,
It's love. Wait,
okay.
what were you asking?
Because I feel like that's why I asked.
Oh, okay. Wait.
Okay,
Okay.
don't don't get upset. I'm just asking casually.
No, no, I would no, I wouldn't. I was just wondering. Wait, did I say something
No,
that's
no. I can understand people's pulse without just like okay. You will not gonna understand what I'm talking about.
Oh, okay,
Okay,
okay. Other signs of Turner syndrome include a short stature, cystic hygroma, wet neck, swelling of the hands and feet, coarctation of the aorta, bicuspid aortic, horseshoe kidney, infertility. Additionally, due to decreased estrogen concentration, patients fail to develop secondary sexual characteristics. Vital signs are normal. Diagnosis is made to karyotype. Increased concentration of LS and FSH due to lack of negative feedback from estrogen may also help, but these findings are not specific. Okay,
okay.
next.
A 26-year-old woman gravida 3 para 2 comes for her prenatal visit 11 weeks of gestation. Her previous pregnancies and deliveries were uncomplicated. Her blood group is O negative. She received Rh immunoglobulin after her first delivery. Which of the following is test is to evaluate her Rh status? Maybe last. Okay.
Okay, so it is the indirect antiglobulin test. The indirect antiglobulin test is conducted by combining the red blood cells that contain the antigen of choice with the patient's serum. If the patient's serum contains antibodies against the antigen, in this case the Rh, the blood antigen Rh, the antibodies will bind to the RBCs. When comes reagent or antiglobulin antibodies added, the red blood cells will agglutinate. When Rh negative mothers delivers a baby that is Rh positive, it is possible that the Rh antigen from the baby blood can enter the mom blood and cause the mom immune system to form antibodies against the Rh antigen. While this carries no significant complication with the initial exposure, a subsequent pregnancy with Rh positive baby can result in severe hemolytic anemia of the newborn, erythroblastoma fetalis. As the mom, antibodies can cross the placenta, causing hemolysis of the fetus RBCs. Rhd immunoglobulin, immune globulin ROGAM acts by binding to Rh positive cells that enter the maternal circulation, preventing the immune system from developing antibodies to the Rh antigen. Therefore, the best way to determine whether the mom has been exposed to Rh positive blood and subsequently developed antibodies is the indirect antiglobulin test. Hmm.
Why it is not E?
It is not a clear Bacchi acid elution test. Is used to quantify the amount of fetal blood to which the maternal circulation has been exposed in order to determine adequacy of Rh immune globulin dosing. It is frequently used when an Rh negative mom gives birth to an Rh positive baby. However, it will not give information on the patient's Rh antibody status.
Like for Rh status, we will do indirect antiglobulin, and then this test, the KB test, KB acid dilution test, when it is done. Because I have seen some of the questions like this test is done actually, and one of the thing in the world, one of the question there is something like this test.
They're saying this used to when you want to calculate how much ROGAM you have to give to the mom.
Okay, how much?
So we already know that the mom has been exposed um, in you already know you already figured out yes the mom has been exposed to the baby Rh positive, so you want to figure out okay how much ROGAM do I give her. That's when you do this test.
Like it is the next test,
Yeah,
probably.
yeah. You can do it like that. Yeah.
Okay.
Mhm, yeah.
19-year-old primary gravid woman comes to the emergency department because of 1 week history of nausea and 1 week history of 1 week history of nausea, persistent vomiting. Her last menstrual period was 15 weeks ago. She has had daily vaginal bleeding for the past month. She has not received prenatal care. Her temperature is 37 degrees Celsius, pulse 80, respiration 20, blood pressure 140 over 90. Examination show fetal edema. Pelvic examination shows a uterine consistent in size. With the 20 weeks of gestation, there is no adnexal tenderness. A serum pregnancy test is positive. Urinalysis is 1 plus protein ultrasonography show bilateral multilocular ovarian cyst with echogenic structure in the uterus. Which of the following is the most likely diagnosis? Isn't it you have said that ultrasonography likes cystic pattern? Is it identiformal?
That's what I'm thinking. But last time I was wrong, so let's hope I'm right this
No, no, you are right. I was speaking your things, so I think you are right.
time. Yeah.
Okay.
Identiformals are either caused by fertilization of an empty egg or by NTA by a single sperm followed by duplication of the paternal DNA resulting in 46 chromosome complete, or by dual fertilization of a normal ovum resulting in 69 chromosomes incomplete. Maternal symptoms include hyperemesis gravidarum or persistent nausea and vomiting related to an abnormally increased beta HCG concentration. They can also cause first semester vaginal bleeding, early preeclampsia, and uterine size greater than expected for days. Complete moles contain no fetal tissue, while incompletes have some tissue. However, neither are viable pregnancies, and no fetal heartbeat will be found on Doppler ultrasound. Pelvic exam may show cystic molar clusters in the vagina, and lab studies will show abnormally increased beta HCG. Ultrasound of the pelvis will also show bilateral multilocular ovarian cysts, thickened luteaces, and echogenic structures in the uterine height, the deformed molesty, as seen in this patient. Now, the deformed moles are treated with dilation and curettage, followed by appropriate contraception and sequential measurement of beta HCG to monitor for development of malignant gestational trophoblastic disease such as invasive mole or karyocarcinoma. These malignant diseases are treated with chemo. It's not C or D. Uh, Multiple gestations can also present with hyperemesis due to increased maternal serum beta HCG. However, ultrasound will show more than one viable fetus in the uterus. It's not ovarian hyperstimulation syndrome. It's an exaggerated follicular response to injected gonadotropin, commonly used in infertility treatment. Hmm. Symptoms include nausea, vomiting, and fluid retention, as well as shortness of breath and blood clots in severe cases. As this patient has not received gonadotropin, okay. And combined ectopic and intrauterine pregnancy, also known as heterotopic pregnancy, is extremely rare. It will likely present with abdominal pain and potential vaginal bleeding related to the ectopic pregnancy. Ectopic pregnancies most commonly present early in pregnancy because of a restricted area of fetal development. An ultrasound in this situation will show a viable intrauterine pregnancy in addition to an extrauterine ectopic pregnancy. Most common in the I never heard that. So two pregnancies, one in the uterus and one outside the uterus. Huh.
It is combined
Okay.
ectopic and intrauterine.
That's the first time. Okay. Next.
A 35-year healthy, a previously healthy 42-year-old woman comes to the physician because of irregular means during the past 7 months. She has had intense mood changes, occasional hot flashes during this time. Her last menstrual period was 6 weeks ago. She is sexually active with one male partner. Uh, they usually they usually use barrier contraception. Which of the following is the most irregular ones?
Ready?
One sec. Okay.
Pregnancy tests should be considered as a cause of irregular menses in all women of reproductive age, especially in patients with irregular use of contraceptives. Okay. Pregnancy may be accompanied by symptoms including mood changes and hot flashes. In women with advanced maternal age, pregnancy must be excluded as a potential cause by obtaining a pregnancy test before proceeding with further evaluation of other causes such as menopause. Um, Measurement of estradiol and testosterone concentration may detect hormonal changes associated with pregnancy or with disorders such as PCOS. Pituitary adenomos, sex cord stromatoma. Pregnancy tests should be conducted before these conditions are considered. Okay, next.
a 24-year-old primary gravid woman, 42 weeks of gestation, is admitted to the hospital for labor induction. Her pregnancy has been uncomplicated. She has a history of serious illness. On admission, her temperature is 36. Pulse is 64. Blood pressure is 130 over 70. 130 over 70. Fetal non-stress testing is reactive. Pelvic examination shows closed, long, posterior cervix. The amniotic fluid index is 3.2. Which of the following is the most appropriate next step? 42 weeks of gestation.
Probably it's a C-section. Between C-section and amnioinfusion. Oh, why amnioinfusion? I don't know. Anyway, ready?
Yes, we both are wrong.
We both have wrong. Okay. A pregnancy is considered a pregnancy is considered posthumous. Gestation extends to or beyond 42 weeks. To or beyond. Postpartum pregnancy is associated with increased rates of maternal and neonatal complications, including meconium aspiration and fetal demise. While expectant management may be offered to select patients, the presence of an unfavorable cervix or oligohydramnios are suspected by a low amniotic fluid index are indications for induction of labor. Oligohydramnios may result from changes in maternal fetal circulation that occur because of aging of the placenta. This is a non-complication of postpartum pregnancy and is associated with complications like umbilical cord compression. Induction of labor can be achieved by giving prostaglandin analog like misoprostol, dinoprostol, or oxytocin. Non-pharmacologic methods of induction include stripping of the membranes and rupture of the amniotic sac. It's not DRE because amnion infusion is the process of instilling fluid into the amniotic cavity. Amnion infusion may be useful for the management of oligohydramnios, especially when fetal heart rate monitor reveals variable deceleration, suggesting umbilical cord compression. In this case, amnion infusion does not address the underlying cause of oligohydramnia, which is postpartum pregnancy and maternal fetal circulatory changes causing the aging of the placenta. Induction of labor is therefore a more appropriate next step in management. Immediate C-section exposes the mother and fetus to unnecessary risks associated with surgery. Induction of labor is a more appropriate initial step. Immediate C-section is indicated if the induction of labor leads to fetal distress.
Okay.
Okay.
A 23-year-old woman gravid at 3 para to 26 weeks of gestation comes to the physician for a follow-up examination. She reports that her daughter had a flu-like illness 2 months ago that resolves without a medical treatment. Her pregnancy has been otherwise complicated. Results of the prenatal lab studies have been within the reference range. Examination show fundal height 34 centimeter. Ultrasonography show polyhydramnios, fetal ascites, skin thickening, infection of which of the following is most likely diagnosis. Okay, okay.
Polyhydramnios, fetal ascites, and skin thickening caused by subcutaneous edema characteristic of hydrops fetalis. Hydrops fetalis is diagnosed by the combination of fluid accumulation in at least two extravascular compartments like pericardial, pleural effusion, ascites, or subcutaneous edema. It is also associated with placentomegaly of polyhydramnios. There are various causes of hydrops fetalis, including iron deficiency anemia, twin syndrome, transfusion syndrome, maternal hyperthyroidism, erythroblastoma fetale, hemolytic disease, and parvo B19. Parvo B19 infection is a gravid woman is associated with spontaneous abortion and fetal non-immune hydrops fetalis. Symptoms of parvo B19 infection in children can include fever, upper respiratory infection, headache, rash, which is usually self-limited. Adults may present with viral prodrome and arthralgias. Okay, next.
You want to stop here?
Oh, sure.
Okay,
Yeah, because we have to do the
Okay. Okay. An observational study in diabetic patient assess an observational study of the diabetes assess the role of increased plasma fibrinogen level on the risk of cardiac event. 130 diabetic patients are followed for 5 years to assess for development of acute coronary syndrome. In a group of 60 patients with normal baseline 60 patients with normal baseline plasma fibrinogen level, 20 develops acute coronary syndrome and 40 do not. In a group of 70 with a high baseline plasma fibrinogen level, 40 develop ACS and 30 do not. Which of the following best estimate the relative risk with a high baseline relative risk of high baseline fibrinogen level compared with the normal baseline fibrinogen high baseline. Over normal. Okay.
Let me see. 60. Wait, this and this is the same. Oh, okay. Let's see if it's that. And then next.
Yes. A study is performed in which a study is performed in which mothers of the babies born with neural tube defect. Neural tube defect are questions about acetaminophen consumption during the first trimester of the pregnancy. At the same time, mothers of the babies born without neural tube defect are also questioned about consumption of acetaminophen during the first trimester. Which of the following measures of association is most likely reported?
Mm, Without.
Okay,
Forgot.
next. At
Mhm.
a specific hospital, patients diagnosed with pancreatic carcinoma are asked about their current smoking status at the same hospital. At the same hospital, patients without pancreatic carcinoma are asked about their current smoking status. The table is constructed. The odds ratio of the diagnostic pancreatic cancer, odds ratio of the diagnostic pancreatic cancer in correct smoker compared without um, pancreatic cancer. Smoker.
I forgot. What was odds ratio again?
Odds ratio
Um,
of the pancreatic cancer
Pancreatic is patient
is
diagnosed
control
with
odds ratio of
compared to patients without pancreatic.
60
50 over 90 over no pancreatic is 50 over. Oh my lord, it is. Feel like I forgot everything. Anyway, ready?
Look at the question. These questions are pretty easy, isn't it?
They are just completely. I haven't looked at biostats in forever. So,
It will happen, I know that.
yeah. Ready?
You yes,
How about the last?
you got the problem. Like these questions, we have to
Mhm.
We
zero.
have done the first question wrong for no reason. Look at the first question. We
D D.
calculate right, but you give which options?
Let me see. I got D
Yes, you
D
are right. I am just
D.
I calculated right by I but I give wrong answer. Like I haven't seen the 40
Mm,
in. Okay.
jeez. Okay, where are the? It's right
Ex
here. Okay.
okay,
Jesus.
okay.
I don't like this explanation.
Explanation is not important in here. You can read the explanation, but
Okay.
okay, you read the explanation. We will go.
I, I don't like these explanations. Two basic measures of association that you should be familiar are relative risk or risk ratio and odds ratio. You should be able to both calculate and interpret them. Risk refers to probability of an event occurring over a certain period of time. Therefore, typically implies a prospective study design. In
Question
think
one.
of one, diabetic patients are followed over 5 years to assess for the development of ACS. That means it is possible to calculate and report 5-year risk of acute of ACS in these patients. Moreover, we can compare 5-year risk of developing acute coronary syndrome in patients with a high baseline fibrinogen level exposure group to the patients with a normal baseline fibrinogen level, not exposure group. In case control studies, like the one described in question 2, patients are not followed over time to determine their outcome. Rather, the outcome, babies with neurotooth defect, is known from the start of the study. Therefore, it is impossible to calculate risk in such studies, but it is possible to inquire about past exposure. In case control study, we calculate the odds of exposure, the chance of being exposed to a particular factor. In case patients, and compare with the odds of being exposed in control patients, those without the disease. For example, question 2, we can calculate the odds of acetaminophen use in mothers having babies with neurotil defects to the mother having normal babies. In summary, oh Lord, relative risk compares the probability of developing an outcome between two groups over a certain period of time. It implies a prospective study design because the patients are followed over time to see whether or not they develop the outcome. Odds ratio compares the chance of exposure to a particular risk factor in cases and control. Since risk cannot be calculated directly in case control studies because they are not prospective, odds ratio is the measure of association used in this design. Relative risk answers the question within certain period of time, how many times are exposed patients more likely to develop a particular event compared to unexposed? Odds ratio answers the question how many times are diseased people more likely to be exposed to a particular factor compared to non diseased people. Both relative and odds ratio are measured on a scale of 0 to infinity. The
I think I
value
need to take a pillow and fall asleep.
is that's what I'm saying. I don't like these things.
But the questions are good.
The questions are, I mean, yeah, they're good. They're good. They're good.
So how you calculate like have do you have you remembered like in how you calculate the odds ratio?
Oh no, I don't remember. No. Mm-mm.
Like you calculate the odds ratio by the formula or the Rendinel formula, like one digit over two digit, and
I probably would use the Randy net form. I just don't remember it.
I
But I
I have
probably
done
would.
it in this formula. I actually
Uh-huh.
don't know the say question to why it is odds ratio. That is my main query.
You actually don't know question two, what is odds ratio?
Why it is odds ratio?
Because it's probably
Case versus
case
control.
control. It's gonna be case control. Yeah.
Where who is case and who is control in this?
Uh,
I
the
can deal
mothers.
the one and three because that is like what can I say, question answer thing, but I am unable to understand the question too. Okay, I'm reading the question too. In case control studies like one described in question two, patients are not followed over time to determine their outcome. Rather, the outcome, babies with neural tube defect, is known from the start of the study.
Mhm.
Therefore, it is impossible to calculate the risk in these patients in such studies, but it is possible to inquire about the past exposure. In case control study, we calculate the odds of the exposure, the chance of being exposed to a particular factor. In these in case patients, those with a disease, and compare with the odds of exposure in control patients, those without the disease. For the example in question 2, we can calculate the odds of the acetaminophen use in mothers having the babies with the neural tube defect to mothers having no. Oh, okay,
Okay.
now I understand. Okay,
Okay.
you got it.
Think so. Yeah.
Like question 3, how can I calculate? Like we know that we need to calculate the which one, like odds ratio. We know that case control is the odds ratio, so one digit over one digit. So we will read the last part of the question, like odds ratio of the diagnostic with pancreatic cancer with current smoker. So smoker and pancreatic cancer. So first line 50 by, like 50 by 40. You got my point. Over non
Mm-hmm.
pancreatic like patient compared to a patient without pancreatic cancer. So second line 60 divided by 80. You got my point. If they told me to diagnose, told me what is the relative risk of the patient diagnosed with pancreatic cancer, then I will calculate 50 over 90 divided by 60 over 140. You got my point.
Okay.
So we will read the last part of the question. According, I follow Randinel this formula because it is very
Mm-hmm.
easy. Like case control and odds ratio. Read the last line. Odds ratio that a patient diagnosed with pancreatic cancer. So with
Mm-hmm.
pancreatic cancer means the first line. If they told you the
Mm-hmm.
smoker, then it would be yeah, ups and down. You got my point.
Okay.
So pancreatic cancer and without pancreatic cancer, with current
Okay.
smoker, without. Okay, you got my point.
Yep.
So if you can do it by yourself,
Mm-hmm.
and then so you understand what will happen in the exam if we don't
Mm-hmm.
do by